when I was given this title, The Development of Inhaled Therapies, I thought that this was kind of a bit of a look back and a look forward in terms of what I would present. And this is not meant to be entirely comprehensive of all the development. It's meant to give you a flavor for what's on the horizon, really. But it does help when you look back at what has been the progress really since the early 90s in this field. And suddenly you can see that there is this explosion, this really exciting explosion of new therapies that is coming through to the stage where, we're almost saturated in the clinic with research trials, and we've got more trials than patients. So this is a very exciting time. I do have some disclosures, some of which do actually relate to inhaled drug therapy companies. So I guess that's good and bad. It does mean I've been involved in some of the development side of things, and hopefully know a little bit of what I'm talking about. Now, what have I got up here? So the first thing I'm going to go to is actually an angiogram. So this is showing the blood vessels, not the airways. I'll come on to the airways soon. And this is a very old slide, and it shows the difference in the blood vessels in the lung between a normal subject on the left and a patient on the right with idiopathic pulmonary arterial hypertension. I'm not sure that the 6 months is necessarily relevant. That could be 6 months since diagnosis, but we know that it builds over time. What you can see is this pruning of the vessels. It's almost like a tree which has fewer twigs and therefore fewer leaves on it. And the historic way that we treated this is by getting drug into the bloodstream so that it can then pass into the vessels and help these vessels to dilate and to widen. And you would also want potentially some more branches to grow. So the historic approach has been to get blood into to get drug into the bloodstream. And the way this is done, this is a very simple circuit diagram with the heart here, which pumps oxygenated blood around the body. So these are all the organs that your heart pumps blood to. One of them, of course, being the stomach. So we would ingest drug into the stomach, and it would get pumped, and it would get pumped back to the heart, and then enter into the lung and enter into all of the blood vessels of the lung. So that will be the historic way of doing it, or for example, an intravenous infusion such as prostacyclin, which goes directly into the vein and then into the lung. So that seems to work pretty well. We know that. So why would we develop inhaled therapies? Well, there are 5 reasons, and I'm going to go through these throughout the next 10 minutes or so. So one would be to get drug into the lung, which is where the disease is, where it's most likely to give you the most benefit, and not give you harm. So, for example, there might be side effects if that particular medicine can get to other parts of the body. Alternatively, it could be to get therapy into the body that can't be easily taken by mouth. So, for example, if you were to take sort of prostacyclin-based therapies, so like treprostinil, for example, or Orenitram, that directly can be difficult in terms of some side effects. So one way is to get it straight into the lung where it may not cause those side effects. If you've got a very short-acting drug, so a drug that, for example, only lasts for about 5 seconds, then clearly it's got to get straight to the place where it's going to do its job. So that would be with a continuous gas. And then the other, number 4, is to get a therapy closer to the site of the disease where there will be minimal spillover to the rest of the body. And then finally, you might want a drug that you can just take a quick puff of prior to doing any exercise, for example. So you want something that gets there quickly, doesn't take time to absorb, and then works in order for you to then get on and do the activity of interest. So if we look at the anatomy, it makes sense. Here's the sort of the big overview on the left, and then you can see on the in the middle you've got the trachea, which is the main windpipe. if you inhale drug, it will get down into the tubes, the bronchial tubes and the bronchioles. So for patients with asthma, for example, this is clearly the most sensible way of inhaling drug because it needs to work on these bronchial tubes. Now, to work on the pulmonary circulation, the particle size is going to need to be a lot smaller. So these drugs need to be specially engineered so that it can get right down into the very small airways. And here we've got a blow up of these airways that as they go right down and they get towards the alveolar air sacs, where you get exchange of oxygen and carbon dioxide. But you can see just here, I hope my cursor is showing, just how intimately related these air sacs are to this blue vessel, which is the pulmonary artery carrying blood into the lungs, where the site of the main disease is in pulmonary hypertension. And so here, if we can get drug down to here, it can diffuse across into the vessel and act right at the site of the problem. So I'm going to talk a little bit of history now, and I'm going to talk about how we can deposit drug in the area where it's most likely to do benefit and not cause harm, and also where it can be difficult to administer by mouth. So back in the early 90s, and thanks to Werner Seeger for providing some of this history for me, they were looking at patients with a syndrome called ARDS, acute adult respiratory distress syndrome. So this is something that typically happens in patients on the intensive care unit. And you can see in this patient who's been scanned, who's lying on their back, that the normal lung here in black is at the front of the chest, and where they've been lying on their back, the back of the lung is filled with effectively with fluid. Now, if you were to give a drug by intravenous infusion or into the stomach, it will go into the blood circulation and be distributed to the whole of the lung. So you'd have drug going to this area and this area. Now, clearly, there's no air getting into this bottom area. So if you open up the blood vessels in this bottom area, then you're going to get more blood going through bad lung. And so that means it's not going to be picking up oxygen, which is obviously clearly not what you want. And on the right-hand side, and I'll just draw your attention to these two bottom graphs here. The 3 patients are given drug at time 0. And what we can see is this increase in the amount of oxygen in the blood in relation to how much they're breathing in. So there's an improvement in this ratio, which then wears off after 60 minutes. And this is prostacyclin, which is the drug that many patients are given by intravenous infusion, but this was given in an aerosol. And what we can see here is a drop in something called shunt. Shunt is the proportion of blood passing through the lung that doesn't mix with air. So there's a decrease. So if you administer it via the airways, it goes to the healthy lung and diverts blood to the healthy lung. And you can see the difference here between an infusion of prostacyclin and an inhalation of prostacyclin. So there's a very nice big drop in the resistance to flow in the lungs, which is the same almost as the pressure in the lungs. However, when you give it by infusion, there's an increase in shunt, so an increase in blood going through the bad bit of the lung. When you give the same drug, prostacyclin by aerosol, you get a nice drop in the resistance in the lung and a drop in the shunt. So this was really the first exploitation of prostacyclin in this way. But the problem with this drug, as you all know, or many of you will know, is it's got a short half-life of 2 to 3 minutes. In other words, as soon as you stop administering it, within about 10 minutes, it's all gone from the system. So that doesn't make it at all practical. So that then led the group in Gießen to explore this sort of made-up design to administer inhaled Iloprost, which has got a longer half-life of 20 minutes. So this is in the bloodstream for longer, and this was the first patient ever to receive this. You can see here that her pulmonary pressures dropped very nicely, and her oxygen levels increased very nicely. And this was the first ever inhalation of Iloprost ever given in humans, an improvement in cardiac output. So a very impressive effect. And over a period of a year, this effect was maintained, but of course you have to keep sustainingly taking it at least 6 times a day because of the short-acting nature of the drug. So what we see on the left is something that many of you will be familiar with. This was the initial INEB device for administering Iloprost, and now it's the Brelib device. So this is anything between 6 and 9 times a day recommended. Treprostinil is a longer acting form of prostacyclin. So this has a longer half-life, so you can take it every 4 times a day rather than 6 to 9 times a day. So it does have benefits from that perspective. It's not licensed here not available here in the UK, sadly, but many people around the world will be taking this. So that's an aerosol, but also treprostinil has been developed in dry powder and approved by the FDA as Tyvaso, Yutrepia, and then this is also 4 times a day. And then this drug that's currently in trials about to go into phase 3, which is a once-a-day inhalation of treprostinil with some very nice looking results. So that's on the horizon and very exciting. I did mention this before in my introduction about how you might get a very short-acting therapy to the site of action before it degrades. And so what I'm talking about is nitric oxide, which is an inhaled gas which, when it gets into the bloodstream, disappears within a matter of seconds. So clearly, you've got a very short opportunity to get it to be inhaled in the airways, to get to the site of action, and then to work immediately. It's obviously great because, of course, it's inactivated in the blood, so it doesn't have any effects on the rest of the body. And it can open up the blood vessels in the lungs, decrease the pressure, improve the oxygen content. However, this is the machine that we normally use to give nitric oxide to people on the intensive care unit or in the cath lab, that clearly you cannot be walking around attached to this machine. There have been 2 other devices that I'm aware of that have been developed. One carries a small canister of nitric oxide with it, and this went through some trials, didn't, as far as I'm aware, make it through, but mainly because a lot of it was happening in COVID, and they used a particular metric to measure the efficacy of the drug. So it kind of hit the buffers, unfortunately. This is another device. I think this is the device that has been developed, and I've not seen how far it's progressed, but this is ingenious. It recognizes that there's nitrogen and oxygen in the atmosphere, and if with a small electrical current, you can combine those 2 to form nitric oxide, so you don't even need a canister. I'm not sure where that is in clinical development. I was aware of quite a lot of work before COVID, but I've not heard any more since. So there may be more on that in the future. Now, what about getting a drug to the lungs with minimal spillover? So this might be a drug, for example, that has significant side effects if it gets into the body. So here's an example. This is a drug called Imatinib, which was developed for leukemia and was then found to work quite nicely in pulmonary hypertension. It's not a vasodilator drug, so it doesn't dilate the vessels. What it does is it targets the thickness of the vessel wall. So it's something that doesn't give you an immediate relief, but it works over a period of time. And this was actually very successful as a tablet medication over a 24-week trial published over 10 years ago. And this is the 6-minute walk data showing the 6-minute walk in the Imatinib group improving by 50 meters and the placebo group by under 20. So there was a 30-meter difference, which is quite big on top of patients receiving 2 or 3 therapies. The problem was that it created side effects. And so one thought, therefore, is rather than giving it by mouth where the drug gets to all of these areas, it could be inhaled and get just to the lung so that it could diffuse from the airways into the blood vessels directly. And this was a trial that reported last year. And what they show in this graph is this is the concentration of imatinib in the bloodstream if you were to take a 400 milligram tablet and over 7 days. So you take the tablet, the dose in the bloodstream goes up and then falls down. And with the inhaled dose, you see a much lower concentration in the blood. So in other words, it's sticking in the lung, but not going to the rest of the body where it might cause side effects. Now, unfortunately, it didn't work. It didn't improve the endpoints in the phase 2 clinical trial, and that reported last year. And I think there's still a fair amount of head scratching going on about why that may not have happened. A drug that has been developed that's related to Imatinib called Seralutinib, which seems to work at much lower concentrations than Imatinib, has been developed and was successful and published last year at phase 2. So that's the early phase, and is just completed recruitment into the phase 3 trial, phase 3 being the trial that needs to be done to get approval by the FDA or the EMA. And what this showed is vastly lower levels of this drug in the bloodstream. So this is something called a logarithmic scale. So what this is showing is that actually you've got 30 times as amount of the drug that's held in the lung if you do an experiment in a rat than in the bloodstream. So it may not look like much on here, but what you've got here is 10 nanograms per mil, and here you've got several hundred. Because it's a logarithmic scale. So actually the difference between here and here is massive. And it's above the level required to inhibit this important receptor, PDGF, in vitro, so in a lab. So this was reported this last year. And rather than go through all the data, I thought I'd show you a nice pretty picture. So this is a placebo patient on the left from baseline to week 24 in terms of the blood volume in the blood vessels. And you can see a patient who received Seralutinib on top of 3 background therapies, so heavily treated. And you can see how there's more blood vessels opening up, which you can relate back to the angiogram I showed you at the beginning. Now, I'm coming to the end now, and I think one of the important new developments in the last few years is this increasing trend to bring these inhaled therapies into people with scarring conditions in the lung. So with the idea that if you've got other forms of disease in the lung, if you inhale a therapy, it's going to go to the remaining good areas of the lung. So here's a healthy lung on the left and somebody with scarring on the right. And you can see patches of good lung in here and patches of bad lung. So you want the drug to go to the best bit of lung to work. And there's a drug called mosliciguat, which is a bit like riociguat that some of you might have heard of, Adempas, but in inhaled form. And so this is shown not in that particular patient group in early studies, but done in people with PAH and thromboembolic pulmonary hypertension. Very nice sustained drops in pulmonary pressure after a single dose over several hours. And so that's now in trials in patients with interstitial lung disease, PH. And then finally, an interesting one, as I mentioned just at the beginning, is the possibility of using a fast-acting drug to use as required. So in other words, it's a bit like people who might take a puff of their salbutamol or their Ventolin, or albuterol if you call it in the US, prior to doing exercise. So this is vardenafil. So you'll note it's a similar name to tadalafil or sildenafil. So it's basically like Revatio, as it's called, and then I've immediately forgotten the name, the tadalafil trade name, but anyway, you'll probably know it if you're on it. But basically, rather than a tablet form, there's an inhaled form that you take, and now this was the trial design. So they took people and they did a 6-minute walk test and then a cardiopulmonary exercise test on a treadmill. And then 8 days later, they gave them a single dose, just one dose of this, and then they remeasured their performance on the treadmill and on the 6-minute walk test. And the results, I saw them presented at the American Thoracic Society earlier this year, and they were quite impressive. So that's the concept of taking something just before you need it. Right, I'll finish there. And if there are any questions, I will be happy to take them and answer them if I can.
Thank you very much, Professor Howard. Yeah, we had one question from Luis from the Dutch PH Patient Association, who says, I've had some conversations with HCPs who doubt about whether the inhaled medication will actually reach the place where it's needed for PH. Actually, if enough of the dose reaches the right place. Is there enough scientific evidence to prove them wrong?
Um, yeah, thanks, Louise, for that question. I think it's a very tough one to know, and in a sense, you only know really when you've done the full trial and you can see the results. And I think what's called that into question, and why you ask a question, is why did the Aerovate trial fail? There were good doses of inhaled imatinib, and they weren't even micro doses, yet it didn't work. Was it because the drug didn't get to the right place? And it was hanging around in the right place. So with drugs, for example, like Iloprost or Treprostinil, my view is that in many ways, part of the effect is simply that you're able to get it into the bloodstream and then it circulates around the bloodstream and comes back to the lung. So some of that effect might work that way, but if you're not getting any systemic absorption, any absorption into the bloodstream, and it's simply hanging out in the big airways, then maybe it won't work. So there are quite a few people who are still skeptical. I think the way to make sure that we develop drugs that work is that the particle size has to be small enough, and we have to demonstrate on imaging technology, for example, with labeled drug, that the drug can penetrate deep enough into the lung, and you can also label things and do animal experiments and see where the drug ends up before we then take it through into human development. But I think there is a body of evidence building slowly to say, yes, this may be effective, but I also think we shouldn't throw the baby out with the bathwater and stop focusing on other methods of delivery. Good old-fashioned tablets. Patients like taking tablets rather than having to maybe inhale a drug several times a day or inject or have an infusion. That's where we still need to keep a major focus.
Thanks very much, Professor Howard. We appreciate your presentation today. It was excellent.